the Quality Institute oversees a statewide community health initiative called Conversation of Your Life, which is also known as COIL, which is a program of our mayor's wellness campaign and generously supported in part by the Horizon Foundation for New Jersey. COIL aims to engage communities and residents in crucial advanced care planning conversations. We discuss topics like hospice and palliative care, various advanced directive documents, and how to communicate your wishes to your loved ones and healthcare providers. Our programming is being adapted to various cultures and languages. A public health crisis such as the one we're now facing with COVID-19 tests our strengths and highlights our weaknesses. The pandemic is prompting many people to consider the advanced care directives that they may have been putting off, and we want to make sure that you have the information and resources you need to help you make the decisions about the type of care that you want. We're going to continue to provide resources and have these crucial conversations remotely through digital resources, podcasts, and webinars like this one today. Before we begin, I wanted to go over a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit background noise. And you may ask questions throughout or at the end of the presentation by typing into the chat box. The topic for today's presentation is personal values, advanced care planning, and dementia. Please be advised it is not the intent of this program or its speakers to provide clinical or legal advice. So with that, we're honored today to have Lori Kane, Shanna Siegel, Michelle Smith, and Kimberly Polachek joining us for today's presentation. After a brief introduction from our speakers, we'll have the presentation followed by an audience Q&A session. So Lori, the floor is yours.
Hi, and you're going to advance the slides for me?
Correct.
Okay. Hi, I'm Lori Kane. I'm a geriatric social worker, and I work with Shanna Siegel. She's up there, at least on my screen, who is an elder care attorney, and we work for Norris McLaughlin. A little unusual, I'm sure you're thinking, to have a social worker at a law firm, but a lot of our clients have many issues in addition to legal issues, and so I'm there to help in instances where that's the case. I want to start today by talking about dementia. Many people have ideas about dementia, thinking if someone has dementia, they can never do do advanced care planning. When can you do it? When can't you do it? And so I wanted to really just start with a basic introduction about how your brain works, and I'm talking very basic, and then a little bit about dementia, just in order for you to understand what is going on with someone with dementia and how that will impact their ability to do legal documents. You know, unfortunately, we often get people that come in to see us, and one of the spouses has advanced dementia, and they want us to do legal documents. And unfortunately, in many cases, we can't, because we can't just have someone sign something if they don't understand it. And so this is hopefully going to give you just a little information to see if someone with dementia can or cannot do a legal document. Okay, go ahead, Japa. Okay, so this is your normal brain. You can see kind of the gray matter, all the folds and bends. That's where your memories are going to be stored. The frontal lobe is, it's funny, when I do this in person, I can point, I can't point. The frontal lobe is where kind of your personality lives. The temporal lobe is where your speech lives, and there's a little tiny part which is called the hippocampus, which is really important for memory. And so these are the three areas I'm going to focus on a little bit today. Go ahead, Japa. All right, so very quickly, how our normal brain works. So everything happens in your brain through neurons, and the best way to understand this is if you touch something hot, a message is sent with your neurons to your brain that says, ouch. The message goes back to your finger, and you move it, right? And so that communication has to happen, and that happens with every part of your body. Everything you do is communicated through neurons. Memories are made in that little tiny part of the brain called the hippocampus. So when you see something, when you remember it, it goes into the hippocampus, and then from longer term memory is basically stored in that gray matter, all those folds on top of your head. Your personality lives in your frontal lobes, and so who you are really takes place in your frontal lobes, and then your language in the temporal lobes. Okay. So everybody over time notices that they have changes, and a lot of people get worried, you know, is this normal? Do I have dementia? And so a lot of things do happen. Your brain weight does decline by 10%, doesn't really matter. You are losing neurons in that hippocampus, the memory center. So yes, as we age, we have a little more trouble with our memory, completely normal. You have declining levels of neurotransmitters. So what does that mean? It means that, you know, maybe you don't think quite as quickly as you used to, right? Things are slowing down. So maybe it takes you an extra millisecond to move your finger off of that hot thing because you have a few less neurotransmitters. There's a slowing of information speed processing. So it takes you a little longer to take information in, to think about it, and to give an answer. Again, this is all very normal. Your ability to multitask declines. I don't know about you. I used to be able to talk on the phone and use my navigator in the car. Yeah, no more. I either talk on the phone or use my navigator. Can't do both. Also, your ability to, your executive function, which is the ability to plan and organize, and you know, that declines, but again, you know, in a minor way, and it's not that noticeable. Okay, Deba. In between normal aging and dementia is a stage called mild cognitive impairment, MCI. You're still, for people that have MCI, they're still functioning. They can still be independent, but you're beginning to notice there's some cognitive impairment. There's often memory impairment, executive function, the ability to plan. You're seeing that there are some changes. Again, the person is still okay. Again, and a really good time to consider doing advanced care planning, because you know, because a third of these people will go on to develop dementia. Okay. Okay, so what is dementia? Dementia is a general term for the loss of cognitive functioning. And so that's 2 or more core mental functions and it has to be severe enough to interfere with your ability to do daily tasks. So we talked about mild cognitive impairment, where you have some memory issues, some thinking issues, but you still can do function independently. Dementia is chronic, progressive, and it is always terminal. 2 things are happening. You're having structural changes to the brain. So cells in the brain are shrinking and dying, and of course that's permanent. There's also chemical changes, so those neurons are not working like they're supposed to. Those changes are variable. And the best example of this, if you've been with someone with dementia, all of a sudden, maybe one day they remember your name, whereas they don't usually remember it. So it's variable, so it means that maybe that day those neurons were getting through to that part of the memory. One of the, I think, most challenging things about dementia, especially early on, is that people look normal. You can't look at somebody and know they have dementia, and their social skills, their ability to have a conversation and to talk to people, you retain those social skills through a great part of the disease. And so sometimes it's really hard to know if someone has dementia because you can't really tell by looking at them. Eventually, there will be a decline in physical health, including ambulation and swallowing, which Michelle will later talk about when she talks about hospice, because that's a time when a lot of medical decisions have to be made. Okay. There are more than 85 types of dementia. It's like a big umbrella. And under that umbrella, there's 85 different types. They're all different. There's a lot of overlap. A lot of them start very differently, but generally speaking, towards the end, the decline is similar. And I'm just going to talk about a couple of types of dementia. Okay. Okay, Alzheimer's disease, most people have heard of. It's the most common. Generally speaking, it's diagnosed in people that are over age 65. They believe that it starts 10 years or more before cognitive symptoms impair. appear, so that changes are going on in your brain, but it's not obvious for about 10 or 15 years. You may have heard of plaques and tangles. Those are abnormal proteins that form. So the plaques, if you think of that like a roadblock, right? So the plaques are blocking the spaces between the nerve cells, and so those neurotransmitters can't really communicate. Also, tangles are being formed in those nerve cells, which is causing brain death. And remember, we talked about that gray matter in the brain, how important that is for memories. And that is slowly shrinking. We're going from your brain being 3 pounds to 1 pound. So it's significant loss of structure. Usually Alzheimer's disease begins in the hippocampus. So what do you see? You see people who have trouble remembering new information, and people that have trouble coming up with words. And I don't mean, crazy words. I mean, if you show someone your wrist and say, what is this? They can't come up with the word watch. Okay, so that's usually the sign of Alzheimer's disease is starting. Okay, and this got really small, but if you can see, well, at least it's on my left is the normal brain, and on my right is your brain after Alzheimer's. You could see that big black area on the right, the hippocampus, the memory center is gone. People cannot make new memories. Sometimes I had a client, and I couldn't believe after a minute he would ask me the same question. This was my first experience with dementia. I couldn't believe it, that he couldn't remember something he asked me a minute ago. And in his case, he literally had nothing left in that part of his brain where he could make new memories, and he could never remember anything at that stage. Long-term memories, some, but not short-term memories. Okay. All right, so when you are worrying if someone has Alzheimer's, things like memory loss for recent or new information, repeating questions and stories, misplacing things, sometimes difficulty with familiar tasks. It just becomes difficult to follow directions, problems with word finding, as I said, confusion about time or place. You often see people with Alzheimer's getting lost driving, missing appointments. And probably one of the most insipid issues is this worsening judgment and lack of insight. Because again, people with Alzheimer's for a pretty good part of the disease can fool you really well. They still retain their social skills, but what they don't really have is judgment and insight. And it's called anosognosia, which is one of my new favorite words. And that means is they really have no ability to understand that their cognitive function is not normal. If you know people with Alzheimer's, maybe in the beginning there's some recognition, but they absolutely don't think anything is wrong. And obviously that becomes problematic if you're trying to have someone do different types of advanced care planning. Okay. Vascular dementia is another really common form of dementia, and this is changes in reasoning, planning, judgment, and memory caused by brain damage from impaired blood flow to the brain. So things like a stroke are an obvious example of this, but other conditions like diabetes, hypertension can cause slow changes. And so with the stroke, the changes in thinking can be sudden, but there's also over time mild changes that gradually worsen. Symptoms are inconsistent. You can have good days and you can have bad days. And this actually is the only type of dementia that is preventable. And the thing about this we'll learn in a little bit is that, people have good days and bad days. So it is still often possible for people with vascular dementia to do advanced care planning on a good day. Okay, some of the signs of vascular dementia: trouble paying attention and concentrating. We talked about that slow processing speed. Again, it's normally as you age, you think slower, but this is even more obvious than that. Difficulty organizing thoughts, problems with memory, although not so much as Alzheimer's. Depression is often a sign of vascular dementia. And again, the fluctuation and ability to perform. So some you have good days, good parts of days, and bad days. Okay. Okay, and the last type I'm going to talk about is fronto-temporal dementia. This affects either your frontal lobe, which is your personality, or your temporal lobe, which is your speech. And it really, in many ways, is a progressive loss of personality. So it's the nerve cells in the frontal and temporal lobes of your brain that are dying. This is usually diagnosed in patients under the age of 65. The average onset is 56. So if you think about it, people who are 56 are in the height of their careers, raising families, may have young children. It's a devastating, devastating diagnosis. Often misdiagnosed is a psychiatric problem. And again, the behavior changes or language changes really are the first symptoms. Memory stays intact in the beginning. Okay. So what are the signs of this type of dementia? Often it's very bizarre behavior. Someone starts doing things that are off the wall, and that's why it's often diagnosed as a psychiatric problem. Very poor impulse control, lack of inhibitions, absence of insight and poor judgment. These people really don't think anything is wrong, and they don't know that they've completely changed. They often have total loss of empathy, no emotions, improper emotions, compulsive eating, aggressive behavior. And it's a really clear sign is a very strong rigidity in thinking. There is no amount of reasoning that will help make someone understand, because their thoughts are not rational. They don't have the ability to understand that they have an issue. Okay, so when we talk about the ability to do advanced, I'll just do this slide, Shannon, then I'll turn it over to you. When we talk about the ability to do advanced care planning, we really are talking about whether someone has the capacity, whether they have the cognitive ability to complete a legal document. A degree of capacity needed varies with the complexity of legal documents, and Shanna's going to talk about that. So you may be able to do one legal document, but not another. A diagnosis of dementia does not always mean a lack of capacity. As we said, if someone has variable abilities, you just make sure that you do them in the moment when they have more capacity. You choose the optimal time, and we do this all the time. Most people think, oh, if someone has a memory loss, they really can't do advanced care planning. That's really almost not as problematic as the impaired judgment and lack of insight. Because if you think about someone with impaired judgment and lack of insight making decisions about care at the end of life, they really can't have a full understanding of what these issues are and how it will affect them. So that's often more problematic than actual memory loss. Okay, now I will turn it over to Shanna Siegel, who will introduce herself and continue.
Hi, everybody. Thank you. Thanks, Lori. Dappa, you want to move to the next slide? Terrific. And I am the chair of the Elder Law and Special Needs section at Norris McLaughlin and work closely with Lori. So I want to talk a little bit about capacity and how it differs with different documents. I also just want to get a little bit of a background on the documents themselves. When we're dealing with advanced care planning, there are a number of different documents, and I think it's a source of real confusion for people because there are different terms that are used with regard to these documents. When we talk about a medical power of attorney or a healthcare proxy, that's the document where you name an individual to be able to step in and make healthcare decisions if there comes a point where you're unable to make those decisions yourself. Now, this document is often paired with another document. So somebody might say, well, I have a living will, but that living will, which we're going to talk about in a second, may also have a healthcare proxy component to it. So just to understand that distinction. In order to do a healthcare proxy, you need to have the capacity to do so. But let's talk about first, when is that going to kick in? When is the individual who you've named going to be able to act? Well, this document should really only be used, and you should only be going to the healthcare proxy to make a decision when the individual lacks the capacity to make that medical decision. So, for instance, you might have somebody who has mild cognitive impairment or even early dementia, but they still do have ability to make some medical decisions. In that circumstance, then you would not have the healthcare proxy, but there could be other decisions that they don't have the ability to make, and then the healthcare proxy would step in and make those decisions. This is a document that is available online, so you don't have to get it through an attorney, although you certainly can. And just some of the things to look out for that we see is often people will name multiple agents at the same time. So they'll say, well, I have 2 children, I want to name both of them. The problem with that is, of course, what happens if they disagree. So we always recommend, and the statute does state that you should name one person and then name anyone else in your family or another loved one as a backup agent who could step in if your first agent is not able to do it. It should not be your doctor or a facility employee, but it can be anybody else. In executing the document, it must be notarized or have 2 witnesses who are not named in the document. So a lot of times people will have their family member who they're naming as their witnesses, and that's not legally appropriate. So let's think about whether or not my family member is capable of doing this document. Well, this is a document that really has a fairly low standard for capacity. The individual must know who their loved one is, who they're going to name. They must understand and remember who that person is and their relationship with the individual. Of course, that's one of the later things to go, right? So you could have someone who does have dementia, but they still know who they trust, they still know their loved ones, and in that situation, they would know that they are naming that person to make medical decisions if and when they are not able to make those anymore. So that is a point where it's really, fairly easy to see that somebody could make that decision. The real question comes, do they understand the significance of that appointment? So you might say, well, yes, I would name my child. But do they really understand that naming that child, putting their name down, means that that person is going to step in and make all those end-of-life decisions that they cannot make? And so that's something where you just need to have a little bit more discussion to make sure that they do understand what the proxy is going to be asked to do. But generally, as I said, fairly far into dementia, you could do these documents. Next, Appa. Now let's compare that with an instruction directive or a living will. So this is the document where you actually spell out the medical treatments you would and would not want. So this may address whether you would want CPR, intubation, artificial ventilation, artificial nutrition and hydration, all kinds of end-of-life treatments. This form can be written with an attorney. There's a form available on the New Jersey State website. There are other forms available. There's a document, you may be familiar with, the 5 wishes. So there are a variety of different forms that include instruction directives. Now, instruction directives, although we certainly want people to do them, there can be some issues as to whether or not they can whether they're recognized and whether they're going to be followed in an emergent situation. And that's one of the reasons we really like to have a healthcare proxy in addition to the living will. Because if you go to the emergency room, they're not going to read your living will, but they will listen to your healthcare proxy. So those things are, important to kind of have both documents. So when we think about the capacity to complete this document, it is actually a higher level of thinking than the healthcare proxy. And it kind of makes sense if you think of it, because if I'm trying to make a decision about whether or not I would want to be intubated in a particular situation, well, I have to really understand what that means. I have to know what intubation means. I have to be able to think about what the pros and cons, the risks, the benefits, think about kind of that balancing of my quality of life versus, my survival. So those are all things that really would step into and be involved in making that decision. And it's really quite complex. So you could see how somebody who their thinking is not quite clear, that they would have difficulty with these choices. However, that doesn't mean that you cannot get any information from that individual. So if you have somebody who, often you find people just become overwhelmed if they have cognitive impairment and you're asking them these questions to try to work through a living will, it's really kind of becomes overwhelming for them. And they say, you know, I don't want to think about that. I can't. But you may be able to get an idea of what their values are in more general terms. And they may be able to use that information to then be able to think what they might want in a specific situation. So you might be able to get a sense of how important is it to them to be at home, to, you know, to have a quality of life, those kinds of things. So I would encourage you to have those conversations, even if someone cannot sign a living will. Next step. When it comes to dementia, we find that most living will documents do not address those issues. They usually focus on when an individual is permanently unconscious, when they're terminally ill. They deal with things about you think of pulling the plug, right? Dealing with whether someone will be on a ventilator or get a feeding tube, those type of issues. So, what we can include in a living will, discussion about that are specific to dementia. So even though dementia is terminal, it's certainly not terminal earlier on, but we could have some discussions about other types of treatment issues that will arise before the issues of feeding tubes and things like that. It is important to remember, and I know Michelle will talk about this, that feeding almost always becomes an issue when it comes to dementia. So because of the swallowing issues, this is something that you really want to have conversations early on to address. But we can address other things like whether or not you would want to be hospitalized, whether or not you would want use of antibiotics, given the quality of life that an individual with dementia has. And so you can have conversations with that, and those issues can be addressed in your healthcare instruction directive. So for instance, I would say if I came to a point where I could not recognize individuals, that I really have no meaningful quality of life, that I would not want to be hospitalized, I wouldn't want use of antibiotics, and I would generally not want more aggressive means of treatment. So I would put that in my instruction directive so that my family members would understand that. Next. So the last document that we want to talk about is a practitioner order on life-sustaining treatment, or a POLST. Now, a POLST can be very useful for an individual with dementia. It's not for everyone. It's for individuals who have either a terminal illness or a very a serious chronic illness. Generally, we say that if a doctor wouldn't be surprised if you died within a year, then you've kind of fall into that category of individuals who should use a POLST. It's signed with a doctor or an advanced practice nurse, and it can be signed by a healthcare surrogate, as long as it's clear that that surrogate does have the authority to do it. This document focuses on goals of care. And so again, it can be really useful when we're talking about dementia, because it can address, given the specifics of my dementia diagnosis, what are the things that I would want care, and what would be the goals of that, and when wouldn't I? So it's a little bit broader document, and the important thing is that it becomes an enforceable medical order. And so it's going to be enforced and travel with you wherever you are. So if you go to an emergency room, you would have that. If you go to a facility or rehab, you would have that document with you. And so it avoids some of the problems that we see with living wills, where they're not followed because the legal team hasn't viewed them. Because this isn't considered a legal document, it's considered a medical order, it is going to be followed in situations that a living will would not. So if you do meet the criteria, your loved one meets the criteria for a POLST, I think it's a very useful document to complete, in addition to your other documents that we've talked about. Next. So I guess we'd just like to wrap up by saying, I think it's really important to have the conversation with your family members, speaking with them about what their wishes might be, particularly if you have someone who is showing some signs of mild cognitive impairment. That's really the time, as Lori said, to have these discussions before before they lose the ability to do that. And, one of the things that we have seen is that COVID has shown us that things can change on a dime, but particularly if there's any level of cognitive impairment, that can be drastically, you can see drastic declines if someone is put in a situation of isolation. So you may think I have time to have these conversations, but in a situation of quick decline under COVID, you may not. So we'd encourage you to have these conversations. We'll give you a couple of websites here to get those conversations started. And we hope that you will move forward and do that.
Thank you. Okay, one moment. I'm just pulling up your slides, Michelle.
There we go. Okay, got bumped out there for a second. Okay, so what I'd like to present today is our end-stage dementia care specialty program. We definitely have shared today some insights in terms of the disease itself. We've shared importance of planning, both legally and personally, but I wanted to go into more specifically the treatment aspect for those in end stage or final stage of dementia. Next slide. We in hospice tend not to look so much at the specific disease, but more so the collection of symptoms. As Lori had stated earlier, for all of those 75, and I think we're growing in terms of the different types of dementia, they all look very similar towards those end and final stages. So that's where when we are assessing the individual and looking at their care plan needs, we're looking more at those symptoms. And as the screen is saying here, the impaired function becomes significant in the end stages, the loss of problem-solving ability, emotional ability, and that really kind of addresses that quick change of emotions where patients can go from crying to laughing, calm to irritable, without any obvious cause. The personality changes, behavioral discontrol, those memory issues, we are seeing in the end stages all of those things are impacted, in some part. Next slide. Okay, so when we come up with some care planning for those in the late stage, we're looking at the total impact. So when we look at the dementia diagnoses as a whole, it is the 6th leading cause of death in the United States. Predominantly that is the Alzheimer's, but again, collectively the 6th leading cause of death. Additionally, the advancing stages of the disease will cause 3 times as many hospitalization stays. That's typically where we're starting to get the notification where either the care planning team, the emergency departments, and even the families themselves begin to reach out to us looking for that additional assistance. And then we look at the cost perspective, and just to throw out some calculations from, these are actually from 2013 data, but just to give you a little bit of a glimpse, we're looking at $203 billion estimated for care of patients with Alzheimer's. And it's expected at the growing rate to reach 1.2 trillion by the year 2050. So pretty significant there. Annually those costs that we don't factor in are the additional private and family members who are providing at no cost, and that can even reach up into the 200 billion mark as well. So next slide. Okay. So additionally, when we're looking at care planning, we're looking at both the facility and the family environment. So we at our Medisys Research and Development reached out to some of our facilities and did some polling. What are the greatest concerns that you have for those with the end stage dementia? And you can see here the behavioral and the resistance issues were noted. Nutritional needs, we'll go into a little more on what that actually looks like. Fall preventions, of course, the family components of it. Family are, in this habitual learning and accepting stage, and the facilities are helping with that throughout the process. And of course, the additional staffing demands. It does take more one-on-one time to care for those in the end stage dementia. So the facilities are needing to provide that. And we do have Kim here today, who's going to give us a little bit of insight in terms of what that looks like in an assisted living environment. So I'm going to leave those details to her. But when we look more specifically, the facilities are absolutely stating that end stage dementia does require a different mindset, a different treatment plan, to be able to deal with all these aspects here. So next slide. We are looking at the family component. So when we are polling our families, what is the impact that they're feeling regarding end stage dementia? And for them, it's significant in terms of the burden of caregiving. And we just spoke about that, how there's an untold amount of hours that are put into by family members, by loved ones, that we don't always factor into the bigger picture because we're not quantifying that with a dollar amount. But when we ask our families, the greatest impacts that they're noting, again, is that coming to terms with the disease, what are its effects, what can we anticipate, and dealing with them even in that moment. So the additional burden on being the caregiver, of course, that's time management. It's required more and more time as the disease progresses to be able to provide the needs for the individual. Patients, big one there. There's a lot of unknowables, but there's also a lot of in the moments that you can't predict, and helping family members through that, with the primary caregivers helping them through that as well. And of course, we oftentimes will overlook, and I think it's a really important thing to mention, is the physical toll on the health of the caregiver. Again, it's increasing. It's oftentimes a silent issue. Family members aren't initially reaching out for assistance until the very final stages, but that is a physical toll on the caregivers themselves. And of course, always wanting to ensure that your loved one is being cared for properly, whether it's in the home environment or a facility environment. Next slide. Okay. Oh, sorry, I missed one there. So when we look at different treatment options, and again, we're talking end stage dementia. Earlier stages of dementia, we definitely know that we've seen some changes, improvements, if you will, with medications. They've been shown to have some effects, again, in those early stages to slow or stall some of the progression of the disease. But when I talk specifically about that end stage, there is no cure. When we get to that point, when we talk about continuation on medications, we're really not seeing a great deal of effect with medications at that point. And quite honestly, the side effects from those medications are only adding to much of the confusion and much of the difficulty. So next slide. Okay. Those neuropsychiatric symptoms, those are traditionally, again, what we had been treating with the medication, but it looks very different as the disease progresses, into the later stages. So we're looking at the agitations, the aggression, delusions, hallucinations, all of those type things. Again, medication can definitely help with that in the earlier stages, but we're not seeing the benefits later on. So as that increases, that again is when family members are really reaching out. They need help at that point because the medication is becoming ineffective and they quite honestly don't know where to turn. Next slide. Next slide. There we go. So what can we do? If pharmaceutical interventions are of little help at this point, what can we do? And that's where we started to develop that program. So we're going to go right into that. Next slide. Okay, primary with everything is the training component. When we talk about staff training, of course, I'm referring to not just our staff, but any existing staff. So if the patient is living in a skilled center, a long-term care, assisted living, or otherwise, we're working with that staff as well. Training of the family members, of course, is key to the process. Because they are also still providing, particularly if they're staying in the home environment, those family members are still the primary caregivers. So training them in the various aspects. And part of that, of course, is understanding the disease, understanding what's happening now, what's going to be happening later on, so that they can fully plan and know how to react in that moment when things change or with the continued progression. So addition to that, of the training piece is the safety aspects, the home environment, if they're still mobile, if there's still some wandering going on, how do we keep the individuals safe with that? Skin breakdown is a significant issue. When individuals with the disease progression, they become less mobile, even immobile towards the end stages, and circulation becomes an issue. So monitoring for the skin, ensuring that it's still intact, and working with different bathing techniques that we'll talk about as well, and just working with the appendages to ensure that the circulation is not affecting their skin. Additionally, we go into the nutrition, and I know both Shanna and Lori had talked about the nutritional aspect. What we see in those end-stage dementia is difficulty with swallowing. So of course that affects food and water. So it becomes not just food intake, but hydration issues. So we have worked with adaptations for that. We actually have a specialized cup and a specialized utensil that makes eating at those later stages a little easier for the individual, whether they're doing that themselves or more often than not, we're assisting with that, or family members are assisting with that. And then we go into those non-pharmacological interventions. So next slide. Oh, actually we missed one in here, that's okay. So support of the family unit, again, the emphasis on education on the disease process, common symptoms, and processing with the family members. Family members are also going through a lot of grief, a lot of loss. The individual is, they're presenting very differently from the mom they knew before. So working with the individuals through that, working with the family members through that. Next. So when we start services for an individual, we are meeting with them. We call it the family meeting. Sometimes that can include the different roles in the assisted livings and skilled facilities as well. But we're looking at what are the needs of the individual, what are the needs of the family, and how do we supply that support to them. So we're talking about expectations, and this of course can go into advanced care planning and those discussions as well. What are the needs? If they're in a home environment, the needs are oftentimes different than when they're in a skilled or an assisted living environment. And we're clarifying the different roles within our hospice services of both what we provide and the caregivers themselves. And then, of course, ongoing education. We can never overlook that enough regarding where they're at now and the common symptoms and what we can anticipate in the future as well. Clarifying those misconceptions and the ongoing coordination of patient and family-centered care planning. Next. Okay, I'm going to breeze through this one a little bit because it's really just resources that we're offering to families when we're meeting with them. So next. Okay, understanding the meaning behind the behaviors. Again, when the pharmacological interventions are no longer working, we're working to educate all of those that work with the individual in terms of why are they experiencing different changes in behaviors. We're looking at, is there, the root cause of a pain or some other medical condition that might be going on. So education on what those clues and cues are to help process through those unsettling behaviors. Next. Okay. And again, we're focusing on the non-pharmacological. This is where we're going to go into very specifics. Next. Oh, There we go. So music for comfort. I think many people know about the benefits of music therapy. We provide for our patients, we provide 2 separate CDs. One is a very calming, kind of reflective CD, if you will, and the other is very focused and individualized to the patient. And the concept behind that is for memorable moments, helping to ignite or to have conversation about music that they were listening to at different stages of their lives. Because oftentimes music, will have an effect even during those more advanced stages of memory loss, where, tapping into the brain, the music center seems to hold on a little bit differently. So we're able to use music through that. Next. Okay, our chart of life. And very much like it sounds, it's a poster board, if you will, where we're offering pictures and different symbols reflective of who that individual was. The purpose behind this is to help us all stay connected to the individual. So when we walk to, let's say, a patient's room and we see this chart of life board, we can ask questions of them, or we can make comments about something that might also align with things that we've done in our lives, or talk about different family members that are in the picture that the patient might remember. Next. Okay, the caring with intention, really that focus is about being with the individual in that moment. We all know as the disease progresses, the individual might be at a different stage, and their memory might focus on a different time frame of their life. And we just want to be with them in that moment. It might need to be more compassionate or more more physically led, where we're just touching of the hand. That might bring the calm that they need in that moment, or listening to them if they're talking about something repetitively, just being with them in that moment. Next. Okay, our activity pads and our comfort bears. Again, the purpose for these, and I wish I had a picture to share, unfortunately I don't, is a tactile stimulation. It also can be a distraction, if there are things going on, if they're unsettled, due to other behaviors. The lap blank, or the lap pad, and the comfort bear can be very calming to them and can distract them from other things that are going on. And they also bring a sense of security and familiarity, because they're things that we knew from a different period of our lives. Next. Comfort blanket. This is a weighted blanket. Therapeutically, it's been shown that kind of deep pressure is very soothing, very comforting to individuals. There are many different therapeutic approaches to those weighted blankets, and we have found great benefit for that for our end-stage dementia patients. Next. Okay, this is the specialized feeding. Again, as they progress through that dysphagia, that difficulty with swallowing, there's several things that can occur with that. We can see an increase in pneumonia for those individuals, but I think focusing more so on just kind of educating family members who are the caregivers to assist with, because dehydration becomes an issue, assist with the water. And again, we've got a specialized cup that makes drinking a little bit easier, where they're not having to tilt their head as far back and causing those dysphagia issues. And with food, it's a specialized utensil that makes it easier to put the food into the mouth, whether they're doing it themselves or, again, most often where our caregiver is assisting in that feeding process. Next. Okay, the comfort bath. We find typically with end-stage dementia that your traditional bathtub and showers can be very stressful for them. So we've worked to develop what we call our comfort bath, and it can look very similar to a bedside bath, if you will, but there's a lot of additional components to it, where we're setting that really peaceful environment. We're making it warm, we're making it comfortable for them, so that when we are cleaning them up, it's not a scary experience for them or something that causes them distress. Next. Okay, again, that skin breakdown is paramount. We really, every visit that our nurse goes into, a caregiver is there, and of course we're educating the family to really watch for any changes in the skin. We don't want that to progress because of the immobility, because of the poor circulation. Those things can progress very quickly. Next. Okay, and then we provide to all of our families this dementia care answer book and guest book. And what that does is, one, it's a resource. It helps to further educate the family members. It's a quick grab for them to read. But most important, it allows for family members and, guests who are visiting to journal. Let's share a story that you might have about that individual. Many different things, and it's individualized to the person. So we leave those behind with every case that we have. Again, that's right next to the bed, if you will. It's a quick grab for both the family members and those who are visiting. Okay, next. Okay, so in summary, huge impact. We all know, the numbers that were shared earlier. It's a significant impact, obviously, on the patient, the family, caregivers, and of course, we as a whole as a nation. Our specialty program does help to create more lucid moments for the individual. It increases the family satisfaction regardless of the environment that the individual is staying in. And again, that non-pharmacological intervention, just because we were not and have not continued to see benefits for end stage, we've needed to move on and adapt better programming for them for their care plans. Okay, that's it. Okay, great. Now we have Kim. I'm going to switch the computer a little bit.
Hi, my name is Kim Polachek, and I am a memory care advisor at Arden Courts Memory Care Living. What happens when it's no longer safe or feasible to keep your loved one at home? Well, you may be looking for a memory care assisted living. Not all assisted livings are created equal. Some assisted livings have what they call memory care units, or referred to as a locked wing within their community. At Arden Courts, we are memory care specific in that we were built for the sole reason of caring for those in memory care. Prior to even putting a nail in a stud, there was 5 years of research and design done so that we could provide the best care in the best environment for those people with memory care. Some things to look for in a memory care assisted living would be the design. Are the residents free to meander about, have that independence when needed? Are there visual cues throughout the community? One of the things that we have meandering walking paths in a secured area. It's over 3 acres, our property, and all of the paths lead to an entrance to the building. Within our building, there is also a community area where there's familiar things like a barber shop, a little flower shop. So we can always have that wandering in a safe environment where they are watched and while being secured. Some of the other things to look for is the staff trained specifically to memory care? Is programming geared especially towards memory care? And some of the other things that you might want to look at are your ability to be an active participant in your loved one's care. We have here the way of our layout of design is we have 4 houses where one is a boathouse, one is a cottage, one is a country lane, so that while they're in a familiar surrounding, they also can meander throughout the community. Don't wait. My recommendation would be don't wait until you're in crisis mode to seek out help from an assisted living, especially a memory care, when memory care is involved. Reach out early, get to know the people, get a feeling for many different places, tour, have your resources prior to, assure that the community has support groups for you, resources for you, ongoing education, ask questions, ask a lot of questions and build the relationships. It's a very emotional time going through the memory care journey, and you want to be prepared, and preparation is everything. So definitely go out, see the homes and the communities, and ask questions, build the relationships, and make sure that you are comfortable with the community prior to even deciding on that you need placement. Is there any questions?
First, before we get to the questions, I do want to say thank you to all of our speakers. If you guys can come back on camera. Before we open it up, I just want to remind everyone that this webinar will be uploaded to our website, www.njhcqi.org, later today. And stay tuned, because we're going to have resources available, such as our advanced care planning, preparing for the unexpected one-pager, where we've compiled trusted resources, all accessible from home, to help you and your loved ones start thinking about your wishes and strategies for how you can comfortably approach these important conversations with one another and your healthcare providers. We encourage you to take a look at this document and share it with your friends and families. Now, for questions, we have one right here. Let me pull it up. Is there one document or tool you would recommend as a starting point for individuals who have never had this conversation before?
I would say all of them are good. I don't think there's one that necessarily is better than the other when you're initiating the conversation. I think it's just most important that you have the conversation. There are, of course, quick grab ones online that, you can get in that moment, if you will, when we're talking, more of general wishes. I think that's a great place to start, is just print something out, or just, sit down with a notepad in your family and just make general notations. I think definitely, and Lori and Shanna can go into more specifics in terms of when you get into those legal pieces, that's a different animal. But just generally starting the conversation, I think any tool is adequate to get that started.
Yeah,
and
and
websites that we mentioned, I think, Conversation Project, Conversations of Your Life. I think there's a lot of materials online. So just, do a quick Google search, and, I think you'll come across some really good things. Lori, did you want to name something?
Yeah, there's, and I apologize, I don't remember which one of those sites, but one of those sites has something called a values worksheet. Because really, this is really what we're talking about. If someone has advanced dementia, they can't communicate. Different people have different ideas about what their quality of life is, what their values are. And I have found that tool to be really helpful in starting a conversation about what your values are, and beginning to try to tease out what you would want done in those situations.
If you have trouble finding that, you could just email Lori or myself, and we can send it to you.
Yeah.
And I think to add to that, if I can just take another minute, when you start getting into more of the medical decision making, I think better understanding on what the different types are when we talk about interventions and life-sustaining treatments, to have a really solid understanding on what each different procedure is, I think is very important. And that can go along with a discussion with your medical provider as well, but definitely educating yourself is key there.
Thank you. And I know we're running short on time, but there is this one question that was posed that I do just want to bring up very quickly. They're wondering if you have any best practices for caregivers to communicate with a patient that already has dementia. I know that, Michelle, you mentioned something earlier about music for comfort, but is there any other practices that you guys are aware of that usually?
Again, mentioning a few of the different tactics that we develop in our program. Music, again, because it affects us differently in terms of our memory, but it can be talking points. Just playing music and being present with an individual can evoke emotions. So that's a shared experience. Sorry. That's a shared experience. The chart your life, those are pictures, those are symbols, if you will, to engage in conversation, things that they more readily remember at whatever phase they're at, to have those conversations. It's a prompt, if you will, to say, oh, do you remember that trip we took when I was 10 years old? Those type things. So having those prompts handy. Sometimes just being present is the best conversation. It's just sitting next to them, holding their hand.
Got it. Thank you. And so, yep, we're running out of time. So I do want to say thank you to all of our speakers that took the time to join today. There was plenty of helpful information. And if anyone that's attending, if you have any questions that we didn't get to, you can feel free to email me at dwilcox@njhcqy.org. And if you need to get in contact with one of our speakers, please feel free to ask me and I'll definitely put you in contact with them. So I wanted to say thank you all again, and I hope you guys enjoy the rest of your afternoon.
Thanks very much.
Take care, everyone.